We saved the best for last today. Our last patient has, I was just talking about her, literally the biggest herniation I've ever seen in my career at the L5-S1. It's so big that we're going to have to start really lateral and try to reach over to as far medial as we can to get it out. Shot? Yeah. May have to go a little more medial. Shot. So we're going to aim for the L5-S1 first. Shot. Shot. A lot of arthritis here. A lot of arthritis. Shot. Huh. I'm wondering. Let's get an AP view. So the first step in this surgery is going to be gaining access to the two discs that we're fixing today, the L3-4 and L5-S1. The L4-5 is fused to the bones are fused to each other. Yeah, so we're too medial. Let's go back to a lateral view. That's what I figured. Shot. Just lay still, you're doing really good. Yeah. Shot. I'm not going to be able to start that lateral. Shot. Shot. Tons of arthritis here. You doing all right? All right, you're doing great from my standpoint. We've just got to get past your arthritic facets and spine so we can get down to where the herniation is. That's impressive. Shot. Let's get an AP. Yeah, see again, we're very medial there. Yeah, lateral shot. Lateral, lateral, lateral. See all the arthritis back there? Again? All right. Man. So too medial. Well, if that's the case, I should. Shot. You're okay. Too high. Shot. Yeah, you're fine. Give me some num-num. She's got so much. When I say arthritis, by the way, what I'm really talking about is enlarged bones and joints and ligaments and tendons that are all thickened and closing off the accesses or passages. That's what it means. It means difficult to get to. Shot. Yeah, I keep running up against bone spurs. Shot. All right, AP. I keep running into this wall of bone. See it? Lateral. That at the tip of the needle, by the way, is a massive bone spur. Huh? You see it, right? Yeah. They still. That's it. There's nothing else. Shot. Literally trying to redirect every which way but loose. Oh, maybe? Shot? Shot? Where do you feel that? Can you hear me?
Where are you feeling that, man? In your back?
Shot. I feel there's nowhere to go. It's literally closed off. I just cannot get past the bone spurs. The arthritis. It's too much. It is too much. There's just no way. I can't even get close. I'm going to try coming more medial. Shot. Try to sneak in and just go steeper. Again, it's more bone. Shot. No. I'm running up against a mountain of arthritis. I feel it. There's no pathway. Just lay still. You're fine. Give me an AP. I mean, I could try the other side too, but. See all that stuff around the tip? There is no path. Well, that's incredible. Can you scroll that MRI for me, please? Yeah. The problem isn't the herniation is too big. The problem is I'm not able to get into that foramen. What else could we do here? Let's try. You feel, Jordan, you've optimized the WAG, right?
Move it around a little bit more, but that looks like it's
Shot. 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 Might have something there. Let's see where we are. AP. Her spine is very anterior too. That's pretty close. Are you awake? Any pain in your back or your leg? Lay still. Where?
Right shoulder.
Oh yeah. Shot. Again. Any way we can change the orbit? Maybe the orbit is the issue there. I know we're off on orbit above. Shot. That might be better. Right there. What do you think? AP? Right at the lateral margin of the disc. Just, yeah. Go ahead and go back to a lateral. Yeah, I feel the bone there. It won't let me go more medial. Again, it's the same problem. It's pushing me. Shot? It's pushing me lateral. Shot? Are you comfy? Where does she have? Does she have any pain?
You have pain down your leg?
Where?
Right shoulder.
Anywhere else?
We're asking you about your back, ma'am.
What'd she
Say
say?
that again? Back is fine.
And legs are fine?
Legs are fine?
Yeah, quick AP. I don't know, man. It looks to me like the sacrum is off on orbit. But let's just see what we got here. Yeah, it's pushed it lateral. You see that? Fucking hell, all that bone mass. Very interesting. All right. Give me a wag. Uh-huh. Shot. How do we make her shoulder more comfortable? Wag. Shot. Let's try orbit. Go.
Come forward towards me.
Shot.
Is that better? No?
Other.
Back?
Keep going. Shot. What do you think about that right there? Huh? No, I mean, I don't mean the position of the needle. I mean the view. All right. Let's go up to 3-4. I think it's the same entry point.
Yeah.
Just lay still. It's her shoulder that's bugging her.
Yeah, I'm trying to fix it right
What about letting it hang for a little bit or putting it to her side? What do you think? All right, line me up at 3-4.
We're gonna let it hang.
I don't know. Something to make her more comfortable. Shot. Unfortunately, our lady's shoulder is bothering her. She has a bad shoulder, arthritic shoulder. Poor thing is riddled with arthritis. Shot. Huh? Shot. I didn't hear what you said.
Take the armboard out and put her
Shot.
hand on the pillow. Let's try that.
Shot. Lay still, you're doing great. I feel a herniation already. It's massive. Shot.
See if you can bring the arm up this way.
Shot. All right. Let's go right. 5-1. 5-1, right?
Yes. Okay. Bring the arm up this way.
You're fine. Everything's good.
How's that?
We're trying to get your arm more comfortable. Yeah. She's fine. What do you think would be a better option for her shoulder?
She's just gonna move it herself and get positioned under the pillow. I'm keeping an eye on it.
Stay still. You're doing great. Just bear with us just a little more. Unfortunately, she has a bad shoulder and it's bothering her to lay there. Poor thing. What do you think in terms of positioning in the future if we have that same, if we have to do this again? If I have to come back. Shot? Shot. 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 Where do you feel it? I need to know.
Where do you feel that? Huh?
Shot.
Right leg.
Right leg?
Yes.
How far down?
How far? Low?
How far down?
Is it lower or on top?
AP. What's she saying?
Is it low? Is it low, the pain? Or is it upper leg or lower leg? Is it upper or lower? Just passing the knee or
Yeah.
the knee?
Yeah, it's look at that, how far away we are. We're a mile away. Yeah, that's fine. There's just no way to get there. See all that arthritis there by the tip of the needle? I mean, 3-4 we're fine. It took me 2 minutes to get in. But this whole area, the whole mass back there is all enlarged facet. And I cannot navigate past it. Years of hypertrophy. It's just, I'm bumping up against it no matter where I go. It's solid bone. I've seen these kinds of facets in open surgery. They are literally 5 times bigger than normal. You can't get around them. So what I'm trying to do right now is get around it. But it's pushing me laterally right where I don't want to go. Sean? It's like a rip current, you know? Takes you where you don't want to go. We're going to have to come back and do 5-1 open. As long as she's more comfortable, that's great. I am unable to get in at 5-1 on the right, for sure. The left, I'm close, and I want to take a good look at it. Let's take a look at left. Let's go AP and just see. The left looks closer, but we're still lateral to the disc. Yeah, look how far lateral we are. We're out there by the sacral notch over there. And see, show them the arthritis, the bone that shouldn't be there. That entire facet, all of that, yeah, and lower. Just the whole mass of black. Yep, that's all hypertrophied bone. And the reason it's dark is it's blocking the x-ray picture, so it looks dark. It's so dense. I don't think we're going to be able to get 5-1 on the left. I'm way too lateral. I'm going to have to do it open. I can't do it now open. We're going to have to bring her back and do it open, but I will do 3-4. All right. So we cannot do L5-S1.
No, what do you think? So put some cantaloupe over here then.
You're right.
Okay.
Is she awake? Is she awake? Should I do a discogram?
Yes.
I want her awake just for a few more minutes, and then we'll put her to sleep. Yeah. You're too funny, man. I realize it after you told me. But now I'm with you, right? We're on the same page. So we made a good effort at trying to get into 5-1, but you can actually see it really well on the lateral view. Take a shot. And there's just a huge, huge, huge bone growth. So I'm going to have to go and do this open. Oh well. Are you comfy? Yeah. All right, we're going to put you to sleep in a minute, all right? How bad is that on a scale of 1 to 10? What's the highest it went? 9. Was that where you typically get back pain? We're going to fix that for you, okay? All right, well, we're definitely fixing L3-4. I won't be able to fix 5-1. It's not possible. Will you document unable to access L5-S1 bilateral due to severe arthritis, anatomical constraints? All right, you just take care of her. Let's get her to sleep. All right, so are we live still?
Yes.
All right. So unfortunately, she's just coughing.
Yeah.
Dr. Byrne does?
Yep, I'm just checking.
Shot? Shot? Yeah, we cannot safely access the L5-S1 disc. I tried going on both sides. I couldn't get in. The reason is there's a small little pathway that I take to get there. That pathway, if you look at my hand here, say this hole right here between the facets and the sacrum is the pathway. Because the bone is enlarged so much, it's closed off. And you never know that until you get in the operating room and you try. And clearly, we're trying, and it's not working. Shot? Shot? Now we're going for the L3-4. Now she has a fusion at L4-5. I didn't do her fusion, someone else did. But that said, it's created a lot of adjacent segment arthritis. Shot? She has a big herniation here at L3-4. Shot? And we're going to take care of this, no problem. We're going to have to, though, come back and do an open surgery at the, is that where we are right there? At the L5-S1. There's no other way. Shot. So you documented aborted L5-S1 due to anatomical constraints, enlarged facets. That should be good. All right, let's go ahead and run the video as to why do people with herniated disc actually have back pain, so people can understand the inflammatory nature. In her case, it's not as much inflammation, it's more compression by a mass, which normally we can get into and take out with the laser, but not today, not at 5-1. Procedure where I go in and do a laminectomy and remove a lot of those abnormal facet joints and get the pressure off the nerve.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Yeah. Well, we can talk about that. Yeah, we can talk about that. I mean, I can do whatever you want. General's fine.
I think a general,
If general's better.
yeah, and it's going to be probably the other table.
So the challenges with this young lady is it's not the fact she's had a prior fusion at 4-5. It's really the number one, severe enlargement of the facets. This is a piece of herniation, by the way. Look at that thing. It looks like a pancake. That was at L3-4. That was what was pushing on her nerve at L3-4 on the left. Anyway, the challenge with her, number one, very enlarged facet joints. Why? Arthritis of the facets. When the facets get too big, they push the needle laterally, which means to the side, away from the disc. I can't have that. It means I can't get into the disc. So that's what her facets were doing. Number two, her spine is anterior, meaning it's forward. When the spine is really far forward, away from the back, from the skin where we go in, then the angle that I have of approach, it gets closed off very quickly because the spine is too anterior. So enlarged facets, anterior spine, forces the needle lateral, and we just couldn't get into 5-1. She also has a massive herniation at 5-1, biggest I've ever seen in my career. And you know, there's always a chance with patients they're not going to be able to get one of the discs. I think she's going to need it fixed, but we'll see. We'll talk to her when we're done, let her know what happened, let her know we were unable to get both discs fixed, and we're going to have to come back and do the bottom one with a different type of surgery called a laminectomy. And again, you know, how many times have I had to do that? I've done 800 of these surgeries, and I've probably failed to get into L5-S1 maybe 8 times, so 1%. 1% of the patients I was unable to achieve the goal I set out to because of anatomical constraints. So that's not bad, 1%. That means 1% of the patients need open surgery. The other 99% we can fix without open surgery. This is the herniation as well. And this was a 9 out of 10 concordant, correct? Well, yeah, because I laid off of the plunger, you know. I was trying to be nice to her. Then I decided I had to just get the right result, which is to actually apply some pressure. All right, good. We're almost done. The other 2 patients, by the way, from earlier are gone. They've already been discharged from the center. They're going home. One of them is visiting from Arizona, so he's staying in a hotel. The other one is, I think, lives in Vera or Vero. Which one, Vera? This one lives in Vero. Is that what you said? All right. I need the laser on. All right, very good. Vero. Vero Beach. Ah, how is your friend?
Do you know?
No, I'm sorry. I'm thinking of somebody else.
Okay.
Somebody we operated on last
Oh, he's
week.
doing well.
Good. Happy?
Yes. I'm just worried about compliance.
What? Compliance? Oh, yeah. I'm worried about it too. But I mean, I've spent a lot of time talking about compliance. Look at that inflammatory tissue right there. You guys see the reddish pink stuff? That's where the back pain comes from. You got to get rid of that stuff. It has all little painful nerves in there, like a bundle of sack of bad nerves. Not nerve roots, but little pain fibers. Class 4, type C, right? Dr. Burndas? You come in with the polymodal, I love it. Right over the top. Damn. Well, we're going to be, we're going to be working on this herniation here for a little bit. And that said, I am disappointed we couldn't get L5-S1, but I really tried. And it becomes an issue of safety. You know, if you, as a surgeon, you have to learn your limits. As Clint Eastwood said, a person's got to know their limits, right? I don't remember. Was it Dirty Harry? It might have been Dirty Harry. It sounds like a Dirty Harry line. Of course, I made it, you know, more politically correct. I said a person's got to know their limits, but he said a man's got to know his limits. Of course, he's referring to, I think, a bad guy. Long story short, surgeons have to know their limits. They have to know when to stop and not try anymore because they could cause problems. Yeah, see, surgeons are in a very unique position. Doctors are in a unique position to hurt patients. And it doesn't matter whether you're a surgeon or an anesthesiologist, you can hurt somebody. And you've got to know your limits of what you can do. And if you try to do things you're not supposed to do, then you could end up hurting somebody. And I don't want to do that. So I've been very fortunate. I haven't hurt anybody all these years doing surgery. It's because I'm extremely conscientious about not wanting to create problems for people. And I pay attention to where the problem areas are. And I make sure I avoid problems and don't get into trouble. You know what I mean? I don't like creating problems for other people. I need maybe 3 more minutes. What are we using for irrigation? The old ones, right?
Yeah.
All right, any questions from our audience?
We have a couple comments.
Yep.
The first one comes from Edward McGowan on YouTube.
Hello, Ed.
And his comment was, in joking manner, "That's not fair. He told me mine was the largest and worst herniation."
Well, it was. Ed, yours was, but I mean, have you seen this herniation? Holy mackerel. I don't know if they can see the MRI on the inset, but it is the biggest I've ever seen. Yours was the biggest I think I took out, right? Ed, I think yours was the biggest one we took out. She has the biggest one I'm not going to be able to take out. And hers is honestly bigger than your herniation. So Ed, you still have the record for the largest herniation piece that's ever been taken out. Unfortunately, I can't get hers out at L5-S1. But just take a look at the MRI at L5-S1. That huge thing down there is a herniation. I mean, I've never seen one so big. So unfortunately, I just cannot get to it. You know, and that's why we broadcast too, is I need people to see that, you know, you can't have can't bat 1,000 in surgery. Not every time. You're not going to get 1,000 every single time. There are going to be times we just can't get it done. And we've had plenty of those times. Like I said, I think it's around 1% of the time we've not been able to get it done at 5-1. 1%, that's 1 in 100. All right, just about done. That's the last of that herniation right there. You can see it just underneath the nerve root. The nerve root's just outside this tube. This is all herniation right here. Yeah, thanks. How's the irrigation, guys? There's the epidural fat. This is some scar tissue right where the herniation came out laterally into the foramen. Once again, we are right now at L3-4. She doesn't like that. The nerve is right back there in that fat. So I'm just trying to get as much of this stuff as I can. Let's see the grabber. This is more hypertrophied ligament called foraminal ligament. It's a lateral extension of what's called the ligamentum flavum. Some of you may know about laser. I think that's it. Well, let's see, maybe just a little more right here. Now remember, she had a fusion done years ago, and she has what we call adjacent segment disease, which is where the disc above and below the fusion go bad. Boy, did she blow this out, huh? Yes, tough one. Really tough case. Just underneath the nerve root here. Trying to get all this junk out of there so it's not pushing on the nerve anymore. All right. I think that's as good as I'm going to get it. Let me see the laser one more time. Oh, thanks. calcified and scarred up. Grab her. I think we're done, Dr. Burness. Huh? Bittersweet. You know, I don't like not being able to get what I came for, but I feel like it's just not possible. I think she'll get some relief from this one for sure, but that bottom one worries me. It's huge, you know, and I have a feeling we're gonna have to come back and do that open, which is literally like in 800 cases that would be the first one, because I've not been able to get 5-1 before, but when I'm not able to get 5-1, it's because it's not really as symptomatic, because it's kind of buried down in there. I guess it doesn't move as much, so it doesn't cause as much symptoms. Like typically if I can't get the 5-1 disc, it looks bad on the MRI, but it's not causing the problems for the patient. This one is one that I'm worried will be causing problems for her, and that we are going to have to come back. And I feel that way because the facets are so hypertrophied that there must be a lot of movement, you know, because they're hypertrophied to try to stabilize the segment. So that tells me there must be a lot of abnormal movement going on at that segment, L5-S1, to cause the facets to hypertrophy. You know what I mean? Because the facet hypertrophy is reaction. It's a reaction to instability, what we call glacial instability at that segment. So abnormal movements at that segment that are micro movements that cause the bone to react and get bigger over time. And that's like literally 50 years of hypertrophy right there, 50 years. So whatever she had done in her life to her spine, whatever initiated the instability, say 50 years ago, was some type of a trauma that was so severe that after 50 years the facet joints have enlarged so badly. That kind of hypertrophy doesn't happen in a year or two. That takes literally 50 years. Unfortunately, I wasn't able to get around it. All right, any questions from our audience?
A few.
All right, let's take, you know what, I'll just answer them over there. Just go ahead and run another video for them, and I'll come on over there and answer the questions directly. Thanks, everybody. Great job. It's Dr. Deuk at the Deuk Spine Institute here in Florida with one of my patients who had the Deuk laser disc repair for a back injury, and it was around 6 to 8 weeks ago. And you're back for a checkup. How are you feeling today?
I feel wonderful. I feel great. I feel fantastic. I mean, this is the man. He's the man.
Well,
and I came in with a lot of pain, a lot of pain. I couldn't believe it. And now I'm virtually pain-free. It's unbelievable.
How long did you have your back pain? How did that start?
Oh God, that happened many years ago at work, at least 20 plus years. And I had other surgeries in the past, and they really didn't help. And this last one, it just got so bad that I had to do something. So luckily, through the grace of God, I came here, and
Amen.
Yeah, and I'm A1 now.
Awesome. So you had your surgery. You've been doing therapy. Would you say the pain you had in your back before surgery is still there, or is it gone?
Oh, it's gone. It's gone. I have little twinges now, but they're muscular, and which is fine. That's going to go away over time. But my God, what a relief! I'm ready to get back out there and do all the things I used to do, man. It's kind of exciting. It's kind of fun.
Well, it's important that people understand too. When you have 20 years of chronic debilitating back pain, what happens is the muscles in your back shrivel up and atrophy because you're really not active anymore because it hurts too much. So, you know, we can fix the spine pain, but it's going to take time to rehabilitate the muscles and get them back to normal. So I'm glad we're touching on that. So what does your life look like now that we've gotten rid of your back and leg pain?
Well, yeah, I'm going to go back to what I've always done and what I've always enjoyed doing, which is my automotive hobby. And I'm really looking forward to being able to actually lift things again and getting the contorted angles that I used to get working under cars and stuff. It's just gonna be nice. Quality of life is it's
Not too soon with any of that lifting engines
all right,
and
all right,
contorting your
all
body.
right, yeah, all right. But I have, all kidding aside, I have noticed over the years I developed a way to walk, almost a crab walk kind of thing, and I got used to it, and I got, well, that's the way it's going to be. I don't have that now. I mean, it took a little while because it was some pain trying to get the muscles to come back. But my God, you just stick with it. If you got to get it done, stick with it, because you're going to get better. You're going to get better.
Well, congratulations. Is there anything you want to say to wrap things up to your audience?
He's the man. Come see this guy.
All right, congratulations.
Thank you, doctor.
You're
God
welcome,
bless.
sir. God bless you. We're good. We're good. Hi. Are we good? Are we live?
Yes, we are.
All right.
Yep, we're good.
I'm Dr. Deuk Majan, and we've just completed a Deuk laser disc repair on a patient who our original goal was to fix two discs, the L3-4, the L5-S1. And the L5-S1, they're both really bad blowouts, huge disc herniations, but the L5-S1 is gigantic herniation on both sides. I tried to get to the L5-S1, I couldn't get in. Normally the area that I have to work in, I'm going to show this to you guys. It'll give you an appreciation of just how hard it is, you know, technically to get in. So here it is. I'm going to see if you guys can see that. So there's your spine. There's your L5-S1. And I have to literally go through that little window right there. You see that? So the things that can prevent a surgeon from accessing L5-S1 transforaminally is, let's see how I do this here. Try to point to it. I need a pen. Give me a pen.
Pen?
Yeah, thanks. So I'm coming right through that trajectory there, and you could see if the facet joints right here are enlarged, which hers are about 5 times bigger than normal, they kind of grow in this space. And then the iliac crest, which is this bone right here, actually hers is a little bit more that way, so it blocks off the access to that little space, and I just couldn't get in. Too much arthritis, too much, and it was impossible. I was like hitting a piece of rock just sitting in there, and I went like multiple different areas. There was just no path. Normally I could slide down a funnel and get in there, a bony funnel, but there was no funnel. So I tried, and what was happening was I was aiming for the back of the disc, and the facet joint was so enlarged it was pushing my needle to the side like that. You know, it was literally pushing it over. So if that happens, then you're no longer aiming for the disc, you're aiming for the pelvis, and you know, you're going to end up in the pelvis, which you don't want to be. You want to be in the spine. You're doing spine surgery, not pelvic surgery. So I stopped with not wanting to cause any problems for her. But I was able to get the L3-4 disc fixed, and I feel pretty good about that one. Again, just very disappointed with L5-S1, but no way to predict it, no way to know it's not going to happen. To me, on the MRI, it looked fine. X-rays, it looked fine. It looked like I could get it, but when I got in there, I couldn't. All right, let's take our first question.
The first question, this comes from Miguel Vasquez on YouTube, and he's been saying that, like, hello, good day. I sent you my chest images, and they told me that they were having problems in seeing them because they were encrypted. Do you have any other way to do it, or you're not receiving that? can I answer this for him?
Yeah.
Because I just spoke with Darcy. Hello, Miguel. This is Henry. I'm the video production manager here.
Come on here.
Yeah, I'll come in.
Let them see you.
Let me see.
Become famous, man. Come on.
Hello. So, Miguel, yes, no, I've been trying to contact you over the live stream, and so our representative Darcy and our IT department, Jose, they are currently working on this problem and this issue as we speak on trying to help you out with this. And if this is for the MRI review, we are currently about to upload, or either tonight or tomorrow, our videos of how to upload our MRI images on the PC and for Mac. If you have one or the other, they will. Those videos can definitely help you out to try to figure out your problem and make sure everything's can go smoothly and nothing's encrypted and everything. So we are terribly sorry for the inconvenience, and we really appreciate your patience here, and we're doing everything we can to solve this issue for you. So once again, we really appreciate you just bringing the problem here so we can talk it out. And I hope I can explain this better, and either later tonight or tomorrow, our representative Darcy will contact you and have this whole issue resolved for you. So once again, completely sorry for the situation at the moment.
Thank you, Henry.
No worries.
So there you go. Unfortunately, believe it or not, we have technical issues, not just in the operating room at times, but also with our website and our file sharing platform. But yeah, that doesn't mean we're not interested in helping you. It just means we've got to figure out a way to get your images uploaded to our PAC system. PAC system is how we look at MRI scans. All right, that said, hold on one second.
There's a few comments, and then we do have one extra question.
All right, apologize. So what I was getting at is regarding MRI reviews. The MRI reviews, because we get a lot of them, I mean, I think we had, I want to say, we might have had 15 or 20 in one day.
Yeah.
Kind of a record. When we started the MRI reviews, it was just one or a week or two a week, and we're very happy that I'll take 1,000. We want to help everybody and give them an idea of what's going on, but the volume has gone up. So we've actually modified the MRI review upload page on our website, and as a result of that, we've had some issues with the MRIs transferring from the form we're using, where you upload it, which is Gravity Forms, over to Google Drive, where we finally receive it and then transfer it to our PAC system. And there's an intermediary step, which I won't bore you with details. But the point is, for the people that use the web portal to sweep your DICOM images in and upload it, that we've been having some issues with those files transferring over. We've been working on it for literally a month and a half now with our consultants and our network administrator. We're getting there, and I apologize, as Henry was saying earlier. The other option is to send your MRI images on a CD or a flash drive.
Yep.
And if you mail those in, obviously we'll use those to look at your images. There is a kind of a boom now lately of another alternative that people are using, where they get a link, like an email link from the MRI center, and they can access those images through a secure portal where they have to log in. Problem is, when you share that access point with us, we can't log in for you, and the MRI center usually recognizes our IP address as being out of state, and so then it puts up security barriers. So I don't know how you tried to upload your images, whether it was sweeping your DICOM images off your CD or flash drive onto our portal, you know, our file transfer FTP, or whether you are mailing, or whether you have an email link. But the team will help you, and they help a lot of people, but we're trying to find the best way to do it. All right, so thanks for commenting, but I look forward to reviewing your thoracic MRI.
Next question comes from Tyler Wenk on Facebook.
Tyler.
And this was from in the middle of the procedure. He was like, "I'm having deja vu. I remember when I was the subject of one of your videos. Thank you, doctor. Hope your family is well. And how's the kid? Is he still racing?"
Tyler, how are you? Thank you, and it's great to hear from you as always. Yeah, family's good, thank you. Arias has graduated from Lake Highland Prep in Orlando and was accepted to Princeton for undergrad, and he's just deferred a year so that he can actually race and represent the United States of America with pride and dignity in European Formula 3 racing. So Arias will be racing in FIA F3 next year, and they just announced, this is huge news in the racing world, and for those of you who don't know, Formula 1 that's where every driver in the world wants to race, but only 20 drivers or 22 drivers race there. To get to Formula 1, usually you have to go to Formula 2, and before Formula 2 you got Formula 3. Arias will be racing Formula 3. So there will be 30 drivers, 3 drivers per team. He'll be probably on, I can't announce the team right now, but I will eventually, because I don't want to say who it's going to be until we've signed the contract. But the great news is they've gone from 9 race weekends to 10, and I've seen the schedule, and if the schedule becomes solid to what I think it is, they're going to be racing in Monaco, Monte Carlo with Formula 1. The F3 and the F1 will be racing as a support race together with Formula 1. So when Formula 1's on the track, they'll be in the pits. Then Formula 1 comes off the track, Formula 3 goes on, and vice versa. So anyone that's going to be at Formula 1 race in 2023 in Monaco will see Arias racing representing the United States in F3. It's incredible. And that's the first time in the history of FIA F3 that they're allowing the support series to race in Monaco. The other race that's really cool, they added to the schedule that I think is amazing, is Australia. So they're going to be on a street race, a street circuit. FIA F3 doesn't normally race on street circuits because street circuits are more complicated, more challenging. There's no data, there's no practice. You literally show up and they turn a busy street into a race circuit. And so we're going to be racing in Australia as well, on the Melbourne circuit. And then besides that, there'll be Monza, which is Italy. There'll be Spa-Francorchamps, which is Belgium. There's going to be the Red Bull Ring, most likely, in Austria, and Bahrain in Dubai. Where's Bahrain? No, Bahrain is next to Dubai, I think.
I think so.
I don't know. Sorry, I don't know the details, but we'll be in Bahrain for the first race of the year. And then there's a few more in there. Zandvoort, which is in Holland. Incredible, absolutely incredible opportunity. So very excited. He took a year off of Princeton just to race and try to do the best he could and work his way up to Formula 1. So thanks for asking. Just got the news this week. Contract is coming. Once it's signed, we'll make a big announcement. But of course, we're always looking for sponsors. There's only so much water in my fountain. If you don't know where that comes from, go watch The Cannonball Run. One of the funniest movies out there. It's an oldie. All right, what's the next question?
Let's say question, but comes from Edward once more. We're talking about, this was in the middle of the procedure again. She wins, unfortunately. Dr. Deuk was able to access my L5-S1 after many times. I'm so thankful that he was persistent.
Yeah, thank you. So the comment was made, I was able to get to the L5-S1 and someone else that was difficult and challenging. You're right. Sometimes it's a matter of just literally, here's your target, this little spot right here, and you've got to get past rocks, boulders. You got to go through a little window and get there. And it doesn't matter if you come this way, or you come this way, or you come this way. You go whichever way you can get there. Now, you can't go this way because you got blood vessels and arteries and intestines over here. So you got a window in the back, like probably about this big, of an area that I could try, going in and trying to get down to that one little tiny little target. So I'm able to adjust my entry point and my trajectory a bit, but the target has to be the same, right? You're going for the back of the disc. That doesn't change. Sometimes I could get to the side of that and then I could tilt in and get there, but there was no getting past these facets. They're huge, and I've seen these kind of facets before when I do open surgery. They are quite literally 5 times bigger than normal, and there's no way past them. They're covering everything, and you got to know when to stop. You got to know when you've gotten beat. You got to know when you can't do it, and not put the patient through doing something stupid, some Hail Mary, that you're not catching a football here. You're dealing with a real patient who, if you go too far to the side or too far to the front, or you do something dumb, you'll kill the patient. And I've never killed a patient surgically, because I've always learned when to say enough is enough and it's no longer safe to keep trying. And that's what you have to be able to do as a surgeon, is to know when you've done your best, when there's no other option at that time. I think she's still going to have problems with her left leg, and I think we're going to have to bring her back and do an open surgery. It'll be an interesting open surgery. I plan to talk to her in a few minutes when she's awake and let her know, and then bring her back. Thank you very much for joining us today. It was a good day, except for the last part, and we'll get through it. We'll figure out another way that will work for her. But thanks for joining us. We'll be back again next week, I assume. Yeah.
Yep.
All right. Keep your eyes and ears peeled for Arias Deuk Majin and FIF3 for next season. Thanks.